So, good afternoon to everyone. This is our instruction course on ultra wide field photography, retinal photography, and specifically how it changed my practice pattern. The chief instructor, unfortunately, Dr. Rohan Sawant, could not be with us today. So we shall continue in his absence. And I'll start with an introduction to the course as well as, my topic, which was autofluorescence. We have with us excellent speakers, and I'm sure anybody watching this online at a later date will be benefited by their expertise and experience. So I'm Dr. Devendra Venkatramani. I practice at Panvel at Lakshmi Eye Hospital and Institute, and I'll be giving a brief overview on ultra-wide field color photography and autofluorescence. So what is ultra-wide field imaging? Initially, in the early days, we were using standard fundus cameras, and while there is really no definition as such as to what is a normal field, a wide field, and an ultra-wide field, conventionally, up to 50 degrees of field of view is called a normal field. 50 degrees to 100 degrees field of view is called wide field, and more than 100 degrees field of view is called ultra-wide field. So I'm just showing you a few of the images of different machines that are available in the market today. This is the IDON machine, and this has a 90-degree field of view. So technically it does not qualify for ultra-wide field, but probably a wide field. If you montage the images, you can get up to 133 degrees field of view, and these are some of the images from our patients when this machine was with us for a short time. On the other hand, the Zeiss Claris 500 and the Zeiss Claris 700 provide a 133 degrees field of view in a single image. And if you stitch together two images side by side, actually the computer does this automatically, you can get up to 200 degrees field of view. The other one of which Dr. Prashant Bawankure has this, it's the Mirante by Nidec. Beautiful machine with a 163 degrees field of view in the in one image, and this is just one of the images that Sir has taken and published as a cover image of ophthalmology. And these are the images from Optos, which in a single image can cover 200 degrees field of view in the horizontal meridian. That's important to note. In the vertical meridian, the field of view is a little restricted, and there may be lash artifacts not very clearly seen in these images, thankfully, but you would often see them in an Optos image. So since we have the Optos with us, most of my talk will be restricted to photographs from the Optos machine. Just as a brief overview, this is a very easy to use machine. The patient has to just gradually bring his or her eye to the camera aperture over there, which is covered by a silicone sleeve. So there is, it's protected from dust and inadvertent touching. And here you can see how a technician can gently guide the patient's head, and then the machine takes a photograph in a matter of a few seconds. So it's very easy to use. A little bit of a comparison of the different cameras which I showed you. The first image on your left is a montage of our conventional Topcon fundus camera, which has only a 50 degrees field of view. And stitching together these multiple images, we can see that this patient has a scleral buckling surgery that has been done, and that there are some suture erosions, intravitreal suture erosions in this quadrant, and one more suture which has come out over here. This patient has had a refractive error of about minus 10 degrees, minus 10 diopters. Unfortunately, with the IDON machine, we could not, really image the suture even in a montage view. So this probably was one of the major limitations of this machine. Whereas when we imaged the same eye with Optos, you can see that not only these two, but there's another third suture also that has eroded in another quadrant. So just showing you how the wider field of view can really change your outlook and change your perspective on of a particular patient. Some more interesting photographs. These are images of rhegmatogenous retinal detachment, where you can see the large horseshoe tear inferiorly with multiple smaller breaks and the extent of the RD. And what is more important to understand in all of these ultra-wide field techniques is that the periphery looks a little magnified compared to what it actually is. and definitely magnified compared to the posterior pole, simply because of the linear magnification that is achieved, and also because of the fact that we are condensing a three-dimensional bowl-shaped retina into or flattening it out into a two-dimensional image. So the horseshoe tear in real life is probably not as big as this, but in the Optus photo it looks fairly big. Some more images of rhegmatogenous retinal detachment. I'm deliberately showing these because I think we were all trained with this very meticulous surgical planning and diagram, and we used to draw these very detailed diagrams, much to the discomfort of the patient, and many times we overlooked and persisted despite the patient's discomfort, whereas now we really don't need to. We can have these beautiful images which can be displayed in our OTs as well, and while you're doing your buckling surgery, you can look at this image and identify the landmarks intraoperatively without having to depend upon a meticulous fundus diagram. Obviously, the great value of these images lie in patient education and counseling. These are some images of the two eyes of a patient who has undergone PRP, and here you can reassure the patient that the diabetic retinopathy has regressed and there are no bleeding spots, and these are the laser marks that you had experienced while the laser was being done. Whereas this patient would have unstable diabetic retinopathy, and you can explain the reason for those floaters that he is seeing, and also explain where are the areas that you wish to touch up the laser to, and show him changes over a period of time. So some more images of laser and diabetic retinopathy. A very interesting use of this machine is in retinopathy of prematurity. These images are very difficult to take, and obviously they have to be done in the hospital setting as opposed to the NICU setting. There are special positions of holding the baby that are described, called the flying baby or the Superman baby position, in which the eye can be brought close to the machine. But I think these are beautiful images to educate parents as to what is the actual nature of the disease and how the disease has regressed once you've treated it. So while we all use electronic medical records, the conventional laptop or computer desktop may not be adequate to use in this with this machine. You probably would require a wider field monitor as well as the camera, and once you have a nice large computer monitor, it makes a lot of difference to see those images yourself, because the quality is going to be poorer if your monitor resolution is bad, and here of course patients would not be able to appreciate all the details unless you have a nice large screen to show it to them. Another big value of these images is for teaching, and just as I'm able to demonstrate all of these lesions to you here today, we have postgraduates and fellows where you can show the image to the postgraduate and explain that this is where the operculated hole is. Now why don't you have a look at the patient and follow these landmarks and come to this operculated hole, so that I know that you have actually seen this. Many times, and we are all guilty of this during our residency days, when the consultant would ask us, did you see the lesion? And we would all nod, yes, I saw it, without having actually seen anything at all. Now, one of the described uses of this modality is for pre-operative retina screening. This is a patient who came for pre-LASIK screening, and you can see that there is a pigmented lesion in the periphery, probably just some pigment, but there's a small atrophic hole also associated with it. And we've done a laser barrage, and it's so nicely documented in all of these images. And a nice study done from Narayan Nethralaya, which talked about the inter-observer but also agreement, but also the sensitivity of Optus for screening peripheral lesions in pre-LASIK patients. And they found that the sensitivity or the detection rate was very high, 78%, which as a screening modality is excellent. So it's obvious that if you find even one lesion, you are going to barrage that if you're going ahead with LASIK. So if it's a positive test, then your work is done. If the test is negative, you may then consider dilating the patient and looking at the fundus in more detail. There are limitations of any technology. This is one of the patients who had come for screening, and you can see not only the lash artifact, but here if you inspect the periphery, it looks quite good, quite normal. But in the superior views, you can see a nice pigmented lattice, which you would have missed if you had looked at only the first image. And in the inferior view as well, there's another lattice with holes. So it's important to take these superior and inferior views also and not depend solely on the single view that is focused on the posterior pole. Following up certain specific patients is also, a great application of this technology. This is a patient with a 2 millimeter pupil with ankylosing spondylitis. He's a one-eyed patient. He's had all this laser barrage done in the past. Waiting for him to dilate in the OPD for an hour by putting multiple applications of tropicocel drops just wastes a lot of time. Whereas in one image, you can this is an undilated image. You can see how well the laser has been done, and he does not require any further treatment. So everybody is happy when this is done. Similarly, another high myope whose lattices have been nicely barraged. He's very reassured whenever he sees these images that he has no fresh lesions. And of course, some follow-up studies where you can see how the lesions can improve over a period of time by drainage of blood with intervention or without intervention. Some more interesting cases of dislocated crystalline lenses in an 8-year-old child with Marfan syndrome. And you can see the aura in such exquisite detail. That's the aura. Of course, the child is practically aphakic. That's why you can see so much. But some very interesting photos. So it's an invaluable technology when it comes to surgical planning, patient education and counseling, and all those instances that I mentioned. But it has very important limitations. I don't think we can say that it's a substitute to binocular indirect ophthalmoscopy. You can't use it in a recumbent patient, or you can't really use it in a small child. There's no stereopsis, so sometimes you may not really understand whether there is a mass lesion or not. Dynamic examination is obviously not possible, and as you could see, all the images are red, green in color in the Optus simply because it uses two different lasers, a red laser and a green laser, and stitches those images together, so you get all these false color image artifacts. And of course, the cost is quite prohibitive, so for commonplace use, that's a major limitation. So I've shown some of these images before. This is a series of dislocations of structures into the vitreous cavity. This was a patient who, after anti-VEGF injection, where few air bubbles had also gone in, was very concerned because he was seeing these circles, and we could reassure him that they are nothing but air bubbles which will disappear in a few days. I'll move on to my actual topic, which is ultra-wide field autofluorescence. And while autofluorescence is a technology that has been around for decades and is based on lipofuscin accumulation, our talks today are all focused on how ultra-wide field imaging has changed our practice. So I'll be restricting my clinical examples to some of these clinical entities which are obviously characterized by abnormal lipofuscin accumulation, but where ultra-wide field autofluorescence really made a difference. So this is one interesting situation in a patient with asteroid hyalosis, where the view of the fundus is so poor. This is a diabetic patient, and we're really not sure whether the patient has any level of diabetic retinopathy or not. Doing an autofluorescence can get at least a good amount of detail and can tell us that we're not dealing with any proliferative disease, and also that there are no hemorrhages or hard exudates in the retina. This was the right eye, and this is another patient. The left eye of the patient has very dense asteroids, but you can also somehow make out that there are some yellow lesions in a circinate pattern in the macular area, and the autofluorescence shows that these are the black spots which are the microaneurysms that are leaking over there, and of course few more microaneurysms and hemorrhages. So asteroid hyalosis is not an impediment to autofluorescence, and I think neither for OCT. So I think these are very useful tools in imaging a patient with dense asteroid hyalosis. In fact, we had presented this in 2012 VRSI, role of autofluorescence in asteroid hyalosis. But of course, this was not ultra-wide field at that time. We had used the conventional fundus camera. Now, we're all familiar with this situation of RPE tracts in a patient with chronic CSR, and truly in an ultra-wide field, you can see the extent of that tract and extent of how it's going down into the inferior periphery. Some nice, interesting patients with uveitis. This was a patient who had this mass lesion in the posterior pole inferior to the macula, with folds in the retina in the macula, and the autofluorescence shows hyper autofluorescence at the borders with some stippling. And this sort of pushed us in the direction of posterior scleritis. Of course, that correlated with the patient's symptomatology. I won't say it's the only test you're going to depend upon, but this is a patient with a nodular posterior scleritis where there was hyperautofluorescence because of the activity of the lesion. Now, this is another patient with multifocal choroiditis, and these images are taken over a period of 1 year. The patient has been on treatment with steroids, and there are some disease-free intervals, but we've done serial autofluorescence, ultra-wide field autofluorescence in him, and we can nicely see how initially the disease was active with the hyperautofluorescence. It started becoming inactive. When there was recurrences, there was reactivation and hyper again. And the lesion is creeping along despite treatment because of loss of follow-up. And now new lesions are cropping up in new locations which are not there in the past. So this sequential ultra-wide field analysis really helps us in now having shifted over this patient onto immunosuppressants along with the steroids. This is just one last patient who had very vague visual symptoms. Detailed fundus examination showed only very few spots which are not even visible on the color fundus. But when you do the autofluorescence, you can see the numerous spots in a white dot syndrome that told us that this is a white dot syndrome which the patient has, and it's something you can see the extent of those lesions over here. The last group is patients with heredomacular degeneration. These are this is our autofluorescence in a patient with ABCA4 retinopathy, as it's now called, as Stargardt's is now called. And we can see that the lesions extend into the mid-periphery as well and are not only focused in the posterior pole as we would probably have thought. These are some more eyes that you can see where the extent of the lesion is. And what is classical is this space around the optic disc, the peripapillary region, where there are no flecks. This area is always spared in a Stargardt or ABCA4 retinopathy. And this was an unconventional ABCA4 presentation where there's only macular lesion and there are no yellow pisiform lesions. And we were not sure whether this is an RP epitheliitis or some other disease. But going into literature, and you can see it very clearly over here, you can see this demarcation line. And this demarcation line is something we learned last year is typical of ABCA4 associated disease. So if you have a patient with Stargardt and you're not sure if this is Stargardt or not, if you do the autofluorescence and find this demarcation line, and you can see it in all of, now that we know it's there, we can see it in all of these earlier images as well. And this tells us that this is most likely to be ABCA4 associated retinopathy. The last slide, this is a patient with retinopathy of retinitis pigmentosa, and there are multiple forms of autofluorescence described in RP, but this is probably something that is closest to our understanding, where there's a sparing of the macula and total loss or abnormal autofluorescence in the periphery, and this is probably the only functional retinal tissue currently present in the eye. So with that, I'll conclude my talk. Of course, we can have discussion later on, but it's now my pleasure to invite our next speaker, Dr. Vatsal Parekh, sir. Dr. Vatsal Parekh requires, I think, no introduction. He is a very senior retina specialist from Mumbai, and he has his own hospital, Drishti Eye Care, and he'll be talking on ultra-wide field OCT using the Silverstone Optus image.
Thank you, Devendra, for inviting me for this course. I have no financial interest in the topic of this presentation, and the machine I am using, it's Silverstone. It's SwapSource OCT. The beauty of this machine is that this is image-guided SwapSource OCT. So you can do OCT wherever you want on image, and patient is looking straight into the posterior pole, or the back of the machine. Limitation is that probably as per the convention you can't go beyond equator, but we have been able to do anterior to equator by telling patient to move the eye and seeing that spot and then putting image there, because conventionally superior, inferior, nasal, temporal pictures what you take, OCT is not available on that. So if you put superior, inferior, nasal, retinal, temporal photographs there, OCT is not possible because image won't go there. So I'll take you to some of the cases where I feel that this will improve the standard of care and this would be a useful adjunct. Now, this is the first patient who is one-eyed, corneal opacity, herpetic or something. You see the opacity. This is a slit lamp biomicroscopy. You can't see the optic disc, but this is where optic disc is. And optos, you can see the optic disc. This haze may be because of the corneal opacity. But what I felt was that because of the swapsos, you could see the macula reasonably well. And I think this macula is good, So this patient has a better prognosis of vision with surgery if the macula remains attached, if the graft remains clear. Now, I have found usefulness of this in diabetic retinopathy surgery. Now, this patient has PDR, one-eyed patient, and you can see the extended view. Here there is a detachment below, and you can do OCT. Now, since this is detached retina to a great extent, so the view is reverse. This is the membrane what you are seeing here, and this is the retina here below, and this is the sensory RP and that layer. Now, if you see, there is a plane of cleavage here. This is the vitreous attachment there. So there is no plane of cleavage here. So whenever you do surgery, this would be the area you are likely to create break. And this is the other area. You can see the plane of cleavage here is better. I operated this patient and there was a break here and his retina has remained attached, So you have intraoperative OCT also, but that I think is spectral domain and this is swapso. So this would be much better to plan your surgery comparatively. Yeah. See, this is the area where there would be break likelihood, because here it's attached. I would start surgery somewhere here or here, because this is the area where there is no vitreous schisis. You will be able to lift the membrane. But these are the areas you are likely to create break because this is plastered on the retina. So you can be aware of it. Not that this is necessary because we have been doing this for years together and you can do surgery. But this helps as an additional feature. Now this is another patient with severe PDR and this looks to a novice, this would look like retinal vessels, but it was not because following eccentric injection, all this have reversed or regressed. Now when you do OCT, you see this is the thin atrophic retina here and this was the entire membrane. So the OCT is taken through this. If we go through surgery, you can see that this layer is thicker than retina, this is over the optic disc. This is thicker than retina. So OCT did show that picture clearly. And this is the post-op picture. He had vitreous hemorrhage which is now clearing and optic disc is seen but rest retina is attached. Now, so typically how it helps is that you can do OCT at various levels in a fundus photograph and see here that this area vitreous is detached reasonably well. Here it is attached little more. Here there is a plane of cleavage. Here there is a plane of cleavage. Here there is a definite plane of cleavage. So you can plan your surgery reasonably well, means you will know where to start surgery probably much more easier. Now this is another case where this was helpful to some extent. Now you don't see retina here. It's all fibrovascular membrane or fibrous membrane. Now if you see OCT, this is near the optic disc. This is all plastered. So I did operate this patient, but it created a large break here. And this was more of a surgical exercise. Patient had PL vision. I told him guarded prognosis. So there was a large break which I created here. There was a break here also. And retina did not do well. So probably this would help to delineate better. Another usefulness of this, since this is swapsos, this gives you choroidal thickness also very well. You can measure the choroid and retinal thickness from periphery to center and also in myopia, hyperopia, and you can subgroup and divide them and analyze the choroidal thickness, retina choroid thickness. Now this was a patient who had melanoma or nevus. This is the area. You can see here hyperautofluorescence. This was the OCT. This was ultra wide field FFA ICG, which is possible with this machine. FFA did not show much leakage, some staining, but ICG showed vascular pattern. So this will help to delineate more. Now the biggest advantage I've found with Swepso's OCT is that you can do OCT in a gas-filled eye. This is a macular hole pre-op. 3 hours post-op you can do OCT. And you can see that the hole is closing, and this is 1 day post-op. You can see that the hole is closed, and this is the air bubble what you are seeing. Now if you see the fundus picture, it is not seen so well because this through the air bubble you are going through fundus photograph, but because of Swepso's OCT you can see it well. Now as Devendra showed, this was a patient who had a horseshoe tear which can be clinically missed because the contrast is not there like normal retina. There's a lot of choroidal tessellations. But when you enlarge this picture, you see the horseshoe tear. So I think I was discussing with Ranjit that the advantage of this technology is that you can take photograph and magnify. Because when you see with indirect ophthalmoscope, you are seeing with 20D lens, so you can't magnify. Unless you are seeing with slit lamp biomicroscopy where you can magnify the picture. But here you can magnify all the areas of interest and see what is happening. So here the OCT demonstrated this, and this demonstrated the horseshoe tear which is there in the periphery. Again, another patient of macular hole in a young patient with RP and abnormal vitreoretinal adhesions. I did limited vitrectomy and PVD induction where it was possible safely, and left the rest in toto and put C3F8 gas. The hole is closed, and you can see that the post-op PVD is occurring here. So this is something you can just monitor and understand better what is happening. Again, this is very useful in uveitis patient. You can see the retina and choroid very well, and you can see the involvement of retina as you see in this photograph, and vitreous is what you see in active retinitis, and even choroid you can see and follow up this patient better. This is along with autofluorescence and fundus photograph, which also shows resolution of the lesion. Again, Coates disease, normally we haven't seen any vitreoretinal pathology, but this was a patient of Coates disease. He has not come for follow-up. These are the crystals or exudates, and this is the same area, and OCT done through that shows abnormal vitreoretinal adhesion. So I think this doing as a routine in many patients would open up new avenues of thought process, because this we have never seen earlier. I also found it useful in cases of retinal detachment which are operated. This was a patient who had detachment. There was a break here. Now since this is highly magnified, so it seems so well, but in normal fundus examination you won't see this detachment so well. So the OCT done there showed that this is detachment. There was a hole here, so I topped up the gas little more and gave position, and the retina settled, and I did the laser again and barraged that area. Now I could avoid surgery in this patient, otherwise this was likely to redetach. But however, this patient redetached this was after laser. He remained good for 4 months, and he redetached 6 months later due to PVR process occurring somewhere else. But at least for the time being, it helped to tide over the crisis. Similarly, another patient who had primary vitrectomy, below the gas bubble there was inferior detachment. You couldn't see this hole on clinical examination, but on ultra wide field, because of the scanning laser ophthalmoscope, you can see the holes. The beauty is that with OCT you can confirm that these are holes. Again, I injected some more gas and gave position. Retina settled. Again, it redetached within a week and 2 weeks, and it was increasing, and I thought it was because of the PVR. Now, as you see here, there is a fixed fold occurring in the same area, and OCT confirms that there is a ERM which has a separate age. So it's a mature membrane. So this is what we are seeing clinically. We can now document it with OCT. So he was operated again, and retina remained attached. Now this, I think, is another key patient. Now if you see, this looks like a typical horseshoe tear. This is a high myopic boy, -10, and his father had bilateral detachment, giant tear. I operated. Now we were fortunate to be able to do OCT through this to the pars plana region, and you can see that this is not the horseshoe tear, but this is an enclosed oral bay. So otherwise one would have done laser, not that they would have done harm, But the availability of OCT cleans the diagnosis which otherwise clinically would be abnormal. And even if you do slit lamp biomicroscopy, you will not be able to make out this thin layer of retina there. These are white without pressure, which you see on OCT here. This is lattice degeneration. You have multiple presentations on lattice. Here there are abnormal vitreoretinal adhesions and retina is uneven and thin. This is another lattice with vitreous attachment there. Now, another place where I have found it useful is that suppose this lattice is at equator or anterior to equator, you can depress. But if it is posterior to equator, you can't depress usually. So this will help you to demonstrate holes. Sometimes what happens is that what looks like a hole because of the contrast may not be hole. So this will help you to delineate that. Again, this is how subclinical RD would look. And this is a patient of peripheral tractional detachment. You can delineate the traction so well. So to conclude, since this is Swepsos, it has better penetration than spectral domain OCT. Advantage is that you can do anywhere in a retina up to equator, and it's possible to do through gas filled eye also. So I think it has definite advantage in understanding pathology of the disease process. And this technology would uncover the undiscovered lesions. So it would be a great armamentarium if one can have it for planning treatment and deciding treatment. Thank you for your patient hearing.
Our next speaker is Dr. Prashant Bawankure.
We already had the brief introduction about the wide field imaging and everything. So I would be speaking on why we should have a wide field imaging. Is it just a additional privilege like owning a Mercedes, or is it a necessity in today's day-to-day clinical practice? I will be sharing with you a few of the cases like this. It's not moving here for me. So I think, yeah, this is not there. आप अंतर है यहाँ पे नहीं मूव हो रहा है. So I would be sharing with you some of the cases. Well, this already we have spoken about it. I think we will just come to my last part of it. This is what the difference is. Devendra has already said what we see in conventional ETDRS, you see about 75 degrees of retina, and wide field is about 100 degrees, and what you see in ultra wide field is more than 110 to 200 degrees. So this is the difference in what you see at. So let's see, these are the options currently available in market. These are the features which are available with them. I would be not going. So the basic thing is what is wide field OCT. In a wide field OCT, in fact, sir has a bigger version of it. A total, how much is the length of it?
16 or more.
Huh? No, for us it is 16 millimeter. So, but that is not that big across which we are getting. So in a standard OCT, we have a frame length of about 9 to 12 millimeter, depending upon the machine which you have. But in a wide field which I have, it is about 16 millimeter. So I will just share with you one of the cases. This is a 80 years old mother of a pathologist who had this particular lesion. So if you can see a mount-like lesion where you would like to understand the tissue characterization of this lesion, because at this age you would be always confused whether you have a melanoma or a PCV or what. So we did a wide field OCT for him, and you can see, you can actually see the fluid over here, the lesion. You can move it a bit on the side, and you can see the lesion, and you can understand the lesional characteristic of this on an OCT. And if you can frame it, if you can characterize it, we knew this is a case of peripheral PCV. We decided to treat it with the help of a brolucizumab, which was available to us by then. And then subsequently how it helps is you can see actually the regression of a falling size of or decreasing size subsequently on further injections. And you can see the regression of this disease so beautifully. So this is one of the good uses of ultra wide field OCT. Now, one of the commonest indication is diabetic retinopathy. Let us see how it can help you in also targeted laser therapy. Well, this is the case which came to us, treated elsewhere with panretinal photocoagulation. The angioframes which she was carrying was this. Hardly any information. You see some amount of ischemia here, some capillary non-perfusion in periphery in this area. Beyond that, you do not get much of an information. You do an ultra-wide field photograph, you can see there are lesion masks which are scattered, done, not actually a good PRP, we should say. And in fact, when we did an ultra-wide field angiogram, we not only saw the capillary non-perfusion in the posterior pole, also beyond the equator. So what we learned from this disease is, because our classical teaching has been that it is a posterior pole disease and you need to treat it about 1 to 2 disc diameter away from the vascular arcade up to the equator. That was the standard teaching for pan-retinal photocoagulation. This whole angiograms of in a diabetic retinopathy in certain cases now challenges that concept that you need to, there might be ischemia ahead of equator, anterior to the equator, and second thing is treating these areas also would help in reducing the reduction, lead to reduction in the macular edema in certain cases as well as in neovascularization. Well, this is a case of a retinal vein occlusion. Again, an image from the which we have borrowed it from the patient who was carrying it. Hardly much of an information. And you do an ultra-wide field angiogram for this particular patient, you can actually see the extent of the ischemia, the neovascularization, some telangiectatic vessels in the periphery. So you know actually from where to where you are supposed to do a sectorial laser. Now this is a patient who came with this OCT, which showed he was advised to have a, in the left eye he was advised anti-VEGF injections. Well, when we did a wide field OCT, we could see the sciatic cavities extending much beyond, and so our diagnosis was not, it was not a simple case of macular edema, it was a case of retinoschisis. But why was there sudden gradual decrease in vision in the last few days or last few weeks was the question, and why it should be so cystic. So we wanted to do an fluorescent angiogram for this particular patient. I will directly share with you the angiogram of the right eye, which showed significant macular edema, and you can see the telangiectasia in the periphery with some dropouts over here. So this particular case of a retinoschisis with secondary degenerative cyst in the macula was not necessarily a degenerative cyst secondary to schisis, but it also was being contributed, some superimposed edema was because of this particular pathology, which we lasered, targeted laser which we did in this area, plus an anti-VEGF was given, and the patient responded beautifully. There was a stabilization at least for a pretty long period of time. Now this is another patient who was diagnosed to have retinal detachment and was advised a vitreous surgery. We also probed into the other eye, and when we looked at it, we thought we are seeing some fibrous tissue in both the eyes. So we decided to do fluorescent angiography, and what you look at is a case of FEVR. So importance is how it changed my diagnosis. Had I not done an angiogram, I would have just bothered about the eye which was already patient was complaining of. But in this case, it drew my attention to the better eye, which was asymptomatic. So now first I treated this eye with the lasers, and once I lasered it, I prevented this particular case from precipitating into a retinal detachment even in the better eye. This is a post-operative photograph of the same patient where we have done a fibrous tissue dissection with a silicone oil imposition. Now this is 52 years old female who had floaters and was advised vitrectomy epiretinal membrane. But on a wide field photograph, I thought there is some straightening of the vessels. So on straightening of the vessels, I decided to probe further, and this was a case of a FEVR with secondary vitreomacular traction, and this is the post-op photograph. So just vitrectomy and ERM peel was not enough. You had to dissect a fibrous tissue which was lying over here, and this is a Ozotrex which we treated to help us out in reduction macular edema fast. Well, this is 48 years old man who complained of and diagnosed as a rot spots in both the eyes. And this is the colored, in fact, a wide field photograph where you can see multiple sclerosed vessels in the periphery. This is an angiogram which can show you nearly 360-degree shutdown. And when we did an angiogram, we could realize it had the same picture was there. Patient had a bilateral carotid disease. So how this is helping me in making bigger diagnosis, I would say. Now this is another gentleman who was diagnosed to have Eales disease, and this was the picture which you saw. And the first time, and with a secondary macular hole. And this is the half zone disease. Half zone disease is usually described in a cases of ROP. We have for the first time described it in a case of elderly male, and that was again secondary to a carotid disease. And so we drew attention to an impending morbid condition, and we could refer him to the physician and help him out in getting a systemic treatment done. Now this is another 26 years old girl who had Mantoux positive. She had healed choroiditis, but she complained of progressive loss of vision. This was not explicable to us. Somehow we did an FAF, we thought all the lesions are healed. We did an angiogram for this patient, why she had progressive loss, and we saw an ischemia in the periphery which warranted a laser. Another case of a 48 years male who had healed choroiditis, had a bleed. We wanted to do an ultrawide field angiogram, and we did an ultrawide field angiogram. You can see the vascular abnormalities quite in periphery which cannot be captured on a standard fundus camera. And so we did a scatter laser in the extreme periphery as demonstrated in this particular patient, and this is how we could achieve and prevent further bleeds. This is interesting case which I always share in various presentations. Diagnosed as Eales disease, combined vascular retinopathy and advised vitreous surgery. Well, fine, we did this was the picture. We accept that this eye does need a vitreous surgery. But look at the wide field photograph of the other eye. Do you notice something different in the vessel pattern here? That is called a classic pruning of the blood vessels, which we could pick up. We thought before touching her right eye, obviously which needs a surgery, we decided to do a fluorescent angiogram for her left eye, and this patient was then further systemically investigated, and she turned out to have a Takayasu disease. This is another case. A young girl who had a thicical eye in right eye following a VR surgery for vascular tumor. This history was significant. Father operated for glomus jugulare, grandfather operated for some brain tumor. We didn't have the details. And this was the picture. To the best of the eyes, I think we cannot pick up any lesion in this particular patient. We are almost all of us are senior vitreoretinal surgeon. But I was not very happy. I wanted to be sure I'm not missing out something. I did an angiogram. And you can pick out, we could pick out so many vascular tumor lesion, and it was a case of von Hippel-Lindau. And once we did a von Hippel-Lindau, we treated this patient with triple freeze cryo as well as lasers. This is post-op follow-up, which we can do so easily with this. Now the father was asymptomatic, but we decided to investigate. We did an angiogram for him and see what we see on an ultrawide field is a multiple angiomas even in his eye. Even her asymptomatic brother had these angiomas, multiple angiomas in both the eyes. So is the importance of doing a wide field photography when you see a case of VHL in a child, and you should always try to screen the family members. And this is 1 year later, the brother we wanted to confirm whether the lesions has adequately regressed. To our dismay, there were certain new lesions and few of the lesions previously which had not regressed adequately. And this is how ultrawide field angiogram helps you in day to day. Finally, we did a genetic study. We could identify the gene, and this is what the recommendation is doing: wide field fluorescent angiography in such cases of vascular tumor yearly. Now, this is another case of a VKH. You can see a silent choroid and such a large wide field OCT. Another case of a wide field VKH I will show following this. Again, multiple blisters of VKH, which was again a cover page of one of the journals. This is a girl who was diagnosed to have central Berlin's edema. Obviously, it is a case of a Berlin's edema, means intraretinal edema was there. And this is what we found when we did a wide field photography. So it helps you in completing a diagnosis and making a getting the whole picture together rather than jumping on the diagnosis. A 1 month baby diagnosed to have ROP, and this is what we could achieve in this in a flying baby position. We could not only see the tumor lesion but also the seedlings in the vitreous cavity. We could pick it up. Well, this is another thing, triad of leukemia. Rarely do you have all the three features together, and this is one of them. You have a metastasis, you have an infiltration, you have a hot spot, and that is called triad of leukemia. Blunt trauma from a ball diagnosed elsewhere as Berlin's edema. When he came to us, we saw an horseshoe tear. He was not ready, reluctant patient. We showed him a photograph. Well, then he got treated. So this is how this helps us out. Another case diagnosed to have macular edema was advised anti-VEGF over here. And when we did a wide field photography, you can see a subclinical retinal detachment just encroaching the fovea with a horseshoe tear and a beautiful lattice there. So this is how it helps me in changing my diagnosis, or rather convincing. These are other few of the photographs. I will just run through it because of want of time. This is decompression retinopathy. Well, it's not a true color because these are SLO based, and sometimes, as already said, 3D surface to 2D, the sizes of the lesions might be just slightly different. And most importantly, how it changed my practice is that when anyone asks me what is the ROI, this is the return on investment in all this equipment. Besides the fun, besides the satisfaction of having done fully for the particular patient who presents to you, because in a standard fundus photography, you see only 70 to 80 degrees, while aura to aura is 220 degrees, which is now possible to visualize. So you do not sleep with a feeling that I'm missing something. Probably I might have missed something. Thank you once more.
Or is it like a conventional fundus camera?
Difficult question. I would ask my. I hardly sit on the machine. That's the reason. Yeah, side to side it moves. I don't think this way.
Not open.
I think so.
Because
No, mine is spectral domain only. Whose is SS? Yeah, it's a multimodal imaging. So wide field multimodal imaging, that is the thing. You can do right from that. Even retro mode is something new, a newer way of looking. Yeah. Pardon.
even Optos has that, sir, that choroidal image and the, of course, infrared image also. So those options are there.
No, retro mode is the way to look at it. You see the RP as a distance.
Yeah,
if they are disease.
yeah. For drusen especially.
Exactly. Any degenerative disease.
Okay.
Yeah.
On fast. It's like an on fast
Correct.
image. It's my pleasure to invite our last speaker, Dr. Manoj Sasode. Sir is
My talk is on wild field angiography. Already most of the things have been covered. Where the wide field angiography can be used, or what is its utility? Basically, screening of fundus periphery, where you would like to know the vascular abnormalities, capillary non-perfusion areas, NVs, tumors, vasculitis, and it will help in early diagnosis, monitoring the treatment part, as well as the planning the treatment as such, because you know now the diagnosis. The classic fundus camera, guys, already discussed. This is giving you the view of 30 to 50 degrees ETDRS fields, but we are using this Spectralis, Heidelberg Spectralis machine, which gives 110 degrees, and if you tilt it, it can go up to the periphery. As I know, important thing is that you are seeing a single wide field image, same center to periphery, and it gives you the complete image. While in montages and others, you get a single field, or either superior-temporal, superior-nasal, or inferior. So this is the thing where the multiple diseases you can diagnose by just in a single click, and with the Optos as well as on the angiography also, in a few seconds you get the various types of images. So today's talks will contain the pediatric cases, PDR, diabetic macular edema, hypertensive retinopathy, ocular ischemic syndrome, BRO, CRVO cases, peripheral vasculitis, uveitis cases, retinal angiomas, and some miscellaneous pathology. This will be again repetition of Prashant's talk. This was previously we were getting the pictures up to this 50 degrees, but we know that with the wide field, you know that the neovascularization pathology which occurs at this junction of perfuse and non-perfuse areas, and where you can see the multiple neovascularization as well as the earmas here. Here also you can see this is a wide field. This whole area is ischemic. So you are now going to plan the treatment accordingly, as well as you know that there is a NVD also. Here in this case of PDR, already treatment was done. The periphery was left behind or missed on angiography, wide field angiography. You know that this area needs to be taken care of. And this is a PDR case with neovascularization of the disc, NVD. You can see the n number of multiple areas of capillary non-perfusion areas, and in other eye NVs also. This in a single click or single images you are able to see the extent of the capillary non-perfusion. So the treatment becomes easy to plan it, whether it will require only injections or surgery, lasers, and how many times it can be given. This is another case Here again you can see that capillary non-perfusion areas have been extensive 360 degree and 360 degree NVAs at the junction of perfused and non-perfused retina. Here also you can see. Another thing is that this PDR case, clinically it was little bit hemorrhages versus this, but when you do the angiography, you can see plenty NVAs are there, and it will give you the guideline how to manage this case. Here you can see that whole area is CNP areas. This is another case of PDR with multiple NVAs. In cases of the astrodialysis, it is very difficult to say that this is a PDR case or not. But if you do the ultrawide field angiography, you will get the idea whether this is a PDR case or not. This is again in a Dane's cataract also you can do the angiography and you get the idea whether this is a case of PDR or not. In borderline cases, this was a well-treated case and we were feeling that there is no NVs. But when we do ultrawide field angiography, you can detect the multiple NVs in it and you will add the treatment in the form of injections or lasers. This is again, there was a pseudo sense that you are treated well, but these areas were remaining, and this is a common cause of macular edema. Particularly, we don't know why it is not responding, but peripheral capillary non-perfusion areas are very much responsible for cystoid macular edema in the or DME, and that is missed. Now, if you take care, it will be cured. Then again, this is a OCT angiography showing the ischemic maculopathy, but on the periphery, these slides you can see the extent of the new non-perfused areas, which usually are not noted. Nowadays, there is always a debate whether the PDR requires laser or only anti-VEGFs can be enough. But in my practice of 25 years, and you all are seniors, we know that patients are coming from almost 16, 17 years old patients are treated 20 years back only with PRP, and they are doing well. In between, they have not taken anything. It is just the matter of how properly you have done the PRP. If so many areas of non-perfusions were remaining, so obviously the patient was progressing and not responding to any treatment. This is again a case of PDR NVD where someone has treated, and this after angiography you can see this lots of areas where non-perfusion were there and it requires additional treatment, and that information you will get only on the basis of wide field angiography. Then there are certain hypertensive and retinopathies. We don't know the hypertensive retinopathies can cause only peripheral vascular occlusions and neovascularizations. These things can be detected on ultrawide field angiography. You can see that on fundus photograph we were suspecting something, but we did the ultrawide field angiography and it was a bilateral neovascularization process, and they manage very well with the laser. Then another hypertension with branch retinal artery occlusion. You can see this, and on angiography you will know how much is the extent of this ischemia. And this is angiography is nowadays very important. I have done almost 6-7 cases of CRO operated vitrectomy were done. 2 were successful, 4 were not successful. But before doing the surgery, this angiography will help how much extent of the ischemia is there and whether this patient will help for after the surgery or not. Otherwise, you will do a big major surgery in such situation, and it will be wastage of the time and wastage of the everything. So this is again a case of central retinal artery occlusion. You can see that predominantly it is inferior branch artery occlusion. Then in cases of central retinal vein occlusion, it is always a debate of non-ischemic versus ischemic CRO, and the major differentiating point is, apart from clinically angiography helps here. Over a period of time, it is called as 90 days glaucoma, neovascular glaucoma. We know that within, if it has to convert into the non-ischemic retinopathy, the ischemic CRVO, then you have to keep on continuously monitoring whether it is converted into the ischemic changes, and this can be mapped on the photograph itself and see that whether it is progressive or not. This is again, you can see that there are so many non-perfused areas, even though we were treating it as a non-ischemic CRVO. But on ultrawide field angiography, we are able to know now that there are still some ischemic areas. This was a non-ischemic CRVO. After a few days, he came with the diminution of vision, Then we did the angiography. Now you can see that it is converted to the ischemic CRVO. Same thing here again. This is a combined case of branch retinal artery occlusion with CRVO. Here you can see that how much extensive non-perfusion is there. That itself will give you the diagnosis immediately to the patients, whether to further manage, do the surgery or do the extensive treatment or not, and whether it is going to help. Then this BRVOs with collaterals, it was our impression that if collaterals are there, that is a well good going thing. Nothing will happen like in a heart. We know that collaterals are formed means you are not going to develop the myocardial infarction. Same thing was there, but you see that these collaterals were there, but there was a leakage from here. There was progressive lamellar hole formation and lots of area was ischemic beyond the collaterals also. This needed to be treated and addressed, and that is possible only because of wide field angiography. Then even in a simple BRVO cases, we treat casually. How much to be treated is not done. We think that it is only sectoral PRP. Now here you can see that lots of area is remaining and it was not need to be treated and addressed. Otherwise, usually we treat in that quadrant only and expect that there will not be edema or will not be further neovascularization and TRD. Here again, this is ultrawide field will give you that is a hemicentral retinal occlusion with retinal edema again. Another case is that ultrawide field angiography, it will again give you the idea of this is a video angiography. You can a real time picture you can document and see that whether where occlusion is there. This was a case of ocular ischemic syndrome, but in cases of BRAO, CRVO or other vascular occlusions, if you want to do, you can see directly the early phases angiography or video angiography of these patients. Then here also you can see the ocular ischemic syndrome cases. Lots of scapulary non-perfusion areas are there, and this is another case of ocular ischemic syndrome. Here also you can see that already Prashant has shown many pictures of Takahashi, but we have found that these are almost it was a carotid occlusive diseases. This was again bilateral case of ocular ischemic syndrome. Here we will see some pediatric cases, FUR cases. You can see the temporal, some changes were occurring. It was difficult to say that this was a dormant form of ROP or it is a FUR, and we don't do the genetic testing and all those in our setup. But angiography gave us that there are straightening of the vessels and peripheral ischemic areas as well as the neovascularization have been developed and was managed well with the laser only. This is another case of FUR. You can see the exudation and all those in the periphery, temporal periphery particularly, and which leaking vessels and non-perfusion. It is very well manageable with the laser itself. Then this is another case of FUR with dragged macula. With this dragged macula also patient was having 6/6 vision. Over a period of follow-up, she developed the macular hole and there was a leaking areas which we were not knowing. But when ultrawide field angiography was done, usually we neglect such types of cases, unilateral falciform folds or if there is a drag macula, we say that it is like that and some congenital defect is there, accept it and manage. But when we did this angiogram, we come to know that there is a vascular non-perfusion areas, there is a cascade. We did the surgery because of macular hole and her 6/6 vision was retained, and how she is managing God knows. In one eye it is central fovea and other eye it is eccentric fovea, but still it is there. Then another case of Coats disease. You can see this is a 13-year-old girl, Coats girl. In peripheral you can see the telangiectatic vessels. This is all around the fundus. See, these types of pictures are very rare from here. We have managed it since last 3 years with the laser only and still doing well. See this picture, very classical pictures of Coats disease in that too in a female. Then this is a Coats disease, already Prashant also has covered. Peripherally we don't know what is happening, but if you do this angiogram only, you know. This is another case of Coats disease. These are the telangiectatic leaking vessels. And this is one more scar was there of congenital toxoplasmosis. This is a course in adults. You can see that peripheral lesion. What was it? We were feeling a retinal angioma or tumor or something. But we did the angiogram and then found the telangiectatic vessel, and it was very well managed in course in adults. Then this is a congenital retinoschisis. You can see this one. There was an inner layer breaks, large wide breaks were there, and just out of curiosity we did the angiography, and you see that there is no blood vessels at all in those areas. Then there are certain uveitis cases where you benefit by ultrawide field and angiography. Here you can see the early phases, wide area of papillary non-perfusion, and later on there is a leakages. Same thing, then vaso-occlusive disorders are there with the cystoid macular edema. You can see that this vaso-occlusive retinitis. Then many cases of pars planitis with cystoid macular edema. If you do the wide field angiography, you will find some vascular abnormalities or phlebitis in the periphery. So they require systemic treatment. Your local treatment won't help. Then this was a Behçet's disease. When patient presented to us was like this, we managed with the systemic therapy, but he was not tolerating. Again, further progress when did the angiography. You can see that for a extensive areas, and this is almost a 32-year-old boy. So this was a Behçet's, and now we have started the treatment for Behçet's by an therapist. Then this was a Ills-like disease. Then when angiography was done, this was again vaso-occlusive disorder. So we did the whole investigations for the antibodies and all. Then she was turned out to be ANA positive. Then Ills vasculitis and all these are very common. We know that how much is the extent of the CNP areas. If you don't address it, it will keep on recurring and will cause the blindness. This is again a vaso-occlusive vasculitis or retinitis case where on ultra-wide field angiography only you can find out the exact pathology. Otherwise, such types of things are missed by expert retina surgeons, also retina specialists also. So in conclusion, it is necessary to know and to confirm the exact diagnosis before deciding surgery, before seeing the response to the treatment. On to add on the treatment, you need ultra-wide angiographies. We don't repeat the angiographies, but here we know that it is a safe procedure. In my 25 years of practice, we do several times of dye angiography, but hardly one or two patients got a little bit of itching and anaphylaxis, and it was manageable. So there should not be a fear of dye angiography. Extent of capillary damage and all the severity of the pathology, we can get idea before starting the treatment itself. So the counseling of the patients and planning of the treatment is very much possible before starting itself. And most of the times we know that there are some hidden pathologies which you were thinking something and you come across with some different diagnosis. So it is very important before deciding the surgery and treatment. And now this is a picture of OCT angiography. Wide field OCT angiographies are now available in the market. One can see this, even though the cost is high, but obviously you can try anytime. Thank you very much. Thank you for kind listening.
2.3 CI. I'm doing. So over the last 5 years, my fluorescein angiographies have plummeted. And ICG angiographies, I send once in 6 months or once in 4 months. So if it is just ultra wide field imaging, then because the major decision maker is the cost, then Optos is still my number one choice, which is what I have. I don't think anybody will regret the machine that they have bought. But Optos has this option of color fundus, autofluorescence, and you have red free and choroidal image, what they call a choroidal image also. But you don't have angiography. You can't upgrade that machine to an angio. You'll have to buy some. Correct. So unfortunately, the angio model is double the cost of the one without the. So how many angios are you doing? Because then you will not use a conventional angio. Or you may wish to continue with your conventional angiography and use this only for ultra wide field angio. I don't know. Yes.
Exactly. So I think if you
because we are not doing FFA basically because we didn't have idea what we can explore.
Exactly. So the historical perspective is that, you know, no, doing angio for the indications that we were conventionally doing angio for. You know, doing angio in patients with diabetic retinopathy, you know, conventionally now is almost non-existent. Doing angio in patients with AMD is almost gone. So you are doing angio in very new indications for these kind of indications. सबको करना है.
I would sum it up very well as Vatsal sir is saying. It is not that, yes, because our standard fundus angiography was not giving us much added information. Now we have really a lot of indications where you can definitely consider doing it. And that's why at our center, I would not say the angios had plummeted down significantly once the AMD, we thought we are not going to. But this now, when you are more suspicious, these are adding. Newer indications is increasing the number of angios being done at our center now.
So